Afternoon, everyone. Thank you so much for joining us. I'm Shannon Burke, the Director of the Central East Regional Cancer Program. So happy to have you with us today. We have Dr. Nancy Durand with us as well. And so I'll just give a brief introduction of Nancy. I would first like to just thank Caitlin Loudon, our engagement lead for primary care and community engagement lead, for setting all of this up and organizing everything. But without further ado, I'll introduce Dr. Durand. So Dr. Durand received her medical degree from McGill University in Montreal, and she completed her residency in obstetrics and gynecology at McGill University. She's on staff at Sunnybrook Health Sciences Centre in Toronto in the Department of Obstetrics and Gynecology, and her clinical and research interests include HPV, colposcopy, and
hysteroscopy.
Thank you. That's a word I don't say often in my world. Dr. Nancy Durand is also an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto, teaching undergraduate and postgraduate level, and speaks nationally and internationally about HPV virus and vaccination. And she was just telling us about a trip she took to South Africa, so I know this to be very true. So without any further from me, we'd just like to hand it over to Dr. Durand to hear about the role of adult HPV vaccination to prevent disease.
Thank you so much, everybody. I'm just going to now tell me you guys can see slides, yes?
Yes, we can go ahead and see the slides.
Okay, great. You can see them though, yes?
Yes, we can see them.
Okay, good. Great. So thanks so much for giving me the opportunity to speak today, highlighting the role of HPV vaccination in preventing disease. And you'll notice specifically the role of vaccinating adults. And so we're going to really sort of dive deep into that. These are my disclosures. What I'd like to do this afternoon is to examine basically the disease trends and how they've been evolving in males and females, and look at the evidence that we have for vaccinating adults as well as younger individuals, and finish up with tips on counseling for HPV vaccination. So let's first look at disease. When we talk about HPV, we like to divide the types of HPV into low-risk types and high-risk types. So, for example, the low-risk types, the most common, would be type 6 and 11, and these are going to cause 90% of external genital warts and a lot of the low-grade precancerous changes that we see with cervical screening. And type 6 and 11 also cause recurrent respiratory papillomatosis. The high-risk types, there's more numbers, as you can see. And there's many types which are associated with some of the low-grade precancerous changes of the cervix, but most of the high-grade precancers that we see on cervical screening. These high-risk types also are known to cause not just cervical cancer, but also vulvar, vaginal cancer, penile cancer in men, and anal cancer and oropharyngeal cancer in both men and women. Now, the ones that are highlighted in blue and the ones that are highlighted in red are responsible for 90% of the diseases that HPV causes, the diseases and cancers that it causes. Worldwide, HPV now is known to cause 5% of all human cancers in both men and women. The problem, though, is that cervix is the only one where we have a method to screen people to detect them and treat them before they become cancer. The other cancers that we see, so for example, vulvar, vaginal, anal cancer, oropharyngeal cancer, we have no methods for screening. And we face challenges in many areas of the world where they may not have cervical screening like we do. And the reporting and surveillance systems are certainly not adequate for these other cancers. An interesting trend we have started to see is that in high-resource countries like our own, rates of cervical cancer have been declining over the past several decades, while the rates of oropharyngeal cancer caused by HPV in males have been rising. So these trends have been seen in North America, in the United Kingdom, in Europe, and in Australia. Previously, that was true, but we now know that cervical cancer in Canada, which had been decreasing at about 2% per year, is now increasing for the first time since 1984. And for the period 2015 to 2019, which was just reported last fall from the Canadian Cancer Society, cervical cancer is now rising at 4% per year. It's now the highest rate of rise of any cancer in males and females in Canada. And remember that this is a preventable cancer, and this increase in cervical cancer was seen before the onset of COVID in 2020. Anal cancer is also rising around the world, both in incidence and mortality. And we know that a high-risk group for anal cancer is certainly men who have sex with men. But you may be surprised to see that anal cancer incidence now in females is surpassing that in males. And so for us, a very important group of women to remember who are at high risk for anal cancer are women who've been previously treated for high-grade cervical dysplasia or for cervical cancer. And these women are continued at risk for anal cancer. They come in about 10 years later with their anal cancer, which is typically caused by the same type of HPV that caused their cervical cancer. The burden of disease in males caused by HPV is increasing. So not just the benign disease like external genital warts, but also anal cancer, penile cancer, and oropharyngeal cancers in males are rising. And as I mentioned, we have no routinely available or recommended screening methods for these cancers caused by HPV in men. Now, oropharyngeal cancer, how does this present? Typically, it now presents with a painless and large lymph node in the neck. And what that means is that the oropharyngeal cancer, when it's seen and diagnosed, is already metastatic to the lymph nodes. There aren't that many symptoms, and the primary cancer is often very difficult to find, very difficult to see. The most common location is in the tonsils, and then base of the tongue and soft palate. And these cancers are very small and often cannot easily be found. So often the diagnosis is made by actually biopsying the enlarged lymph node in the neck. We know, especially in males, that the incidence of oropharyngeal cancer has been rising rapidly. And for example, in the United States, it's doubled over the past 15 years. What's also interesting is that the ratio for males is 4 to 5 times higher than the rate of oropharyngeal cancer in females. So males are very much at risk for HPV-caused oropharyngeal cancer. So this leads us to the question, why should we consider vaccination of adults against HPV? Well, we know the best practice is vaccination before the onset of sexual activity, but the reality, unfortunately, is many regions of the world have been late adopters of national immunization programs. And in countries like our own, with an established national HPV immunization program, we continue to have low coverage rates, low vaccine uptake in our adolescent programs. And then there's also the issue of equity. Many individuals did not have the opportunity to be vaccinated through the national immunization program, often based on their age. And in many countries, and earlier on in Canada, males were not eligible in the school-based program, and that luckily has changed. So I want you to think about the benefits of adult HPV vaccination two ways. The first thing we're going to think about is the benefit to the population as a whole. This is a public health goal, that we vaccinate adults to fill the gaps that were not reached in our national school-based vaccination programs. For example, as I said, those who did not qualify, special subpopulations who are at risk. And think of this as really a multi-age cohort rationale for vaccination, that we vaccinate adolescents, that we also continue to vaccinate young adults and older adults. The second way we think about the benefit of adult HPV vaccination is also the individual who's in front of us, the benefit to that individual, not just the population. So we're going to see that there is a risk to acquiring HPV later in life, that there is efficacy when we vaccinate even those who are older, and even vaccinating those who already have disease. And it's really our jobs to provide information and the opportunity to vaccinate adults so that that person in front of us can make the best informed decision for themselves. So let's look at risk. What is HPV prevalence? Meaning the chance that you have an HPV infection at any one point in your lifetime. And you can see on the left panel in pink that HPV prevalence gradually declines in women with age, but it doesn't go to zero. So for example, if you look at the age of 50, we can see that HPV prevalence is still pretty high at 35%. And then what's happening over here on the right-hand side in males? HPV prevalence in males is much higher than in females, about 65%, and it's steady regardless of how old you are. So it does not decline with age. We continue to be at risk. So we see that sexually active females and males do remain vulnerable to HPV-related diseases and cancers. Now, you may have learned in training that, yeah, most HPV infections are going to clear on their own, especially if you're younger. So if you're younger, about 80% of the time, your infection will clear. But it's those people who go on to have persistent HPV infection and don't clear it that can lead to the development of cancers and other diseases. And that's who we really want to prevent HPV infections in. Now, you might also think that natural immunity would come when you have an HPV infection, that you're going to develop an antibody response, and this would protect you against future HPV infections. So is that really true for HPV? In fact, it's not. So for women, only about 60 to 65% of women develop any antibody response to their HPV infection when we get HPV naturally. And in men, it's even lower. Less than 20% of men will develop an antibody. So if I'm lucky enough to develop an antibody to my HPV infection, does that help me going forward? Does that protect me against subsequent HPV infections? Not really. In women, it's only about 30 to 35% protective at protecting me against another HPV infection. And in men, if I have an HPV antibody to my infection, it doesn't result in any decrease in subsequent HPV infection. And this contrast, this is natural antibodies to natural infection. Whereas when we vaccinate, we have an excellent antibody response in both men and women that is protective, as we're going to see. We also know that adults who have one HPV-related cancer are at risk for developing another HPV cancer at another site later in life. So for example, those diagnosed with cervical cancer are 8 times more likely to develop vulvar or vaginal cancer. If you have vulvar or vaginal cancer, even higher likelihood that you'll go on to develop anal cancer. And if you have anal cancer, you're 5 times more likely to develop an HPV oropharyngeal cancer. So where are we with our HPV vaccination in Canada? We have had 3 HPV vaccines that have been licensed and approved in Canada over the years. Now, the first one was quadrivalent vaccine, and this protected against 4 types of HPV, type 16 and 18, which cause 70% of cervical cancers, and type 6 and 11, which cause 90% of external genital warts. And this was licensed 17 years ago now, back in 2006. The second was bivalent vaccine, 2 types. It protects us against type 16 and 18, and that was in 2010. And then the 9-valent vaccine, which is the one that we use now, is 9 types, and this was licensed for us in Canada in 2015. So 9-valent includes the original 4 types that were in quadrivalent vaccine and added in the next 5 most common high-risk strains that cause cancers. Our provincial programs now, in all 13 provinces and territories, boys and girls are vaccinated in our school-based programs. And this is done with 9-valent vaccine across the board with 2 doses, except Quebec, where they've announced 1 dose will start this fall. It depends which province you live in, which age the kids will be vaccinated, and it ranges between grades 4 in some provinces to grade 7, for example, in Ontario. The problem is that our vaccination rates in Ontario are not optimal. And this past school year, we had less than 50% vaccine coverage rate or uptake rate in our school-based program. And this is following the catch-ups that we tried to do after COVID vaccine. So we've really had a renewal of vaccine hesitancy, misinformation, and certainly some vaccine fatigue amongst parents who are consenting their children in the school-based program. And this lack of vaccination in our school-based program is what leads us into the importance of looking at vaccination of adults. So first, let's look at the evidence, clinical evidence for vaccinating adult women. So first, I'm going to show you young adults, and this is women up to the age of 26. When they're vaccinated or given placebo, we can see a very high, almost 100% reduction of disease in the vaccinated group, and that's over the first 4 years. If we continue to follow those women after the first 4 years, now out to 14 years, there are no breakthrough cases of disease to the types that are in the vaccine. So excellent long-term duration of these vaccines. And this group of women will continue to be followed out for 22 years. Next, we're going to look at an older group of women up to the age of 45. And again, they're women who are vaccinated or given placebo, and the vaccinated group shows almost 90% reduction of disease, even up to the age of 45. We continue to follow this group of women after the original 4 years, and they've now been followed out to 10 years. And again, no breakthrough cases of disease caused by those 4 vaccine types. So that was quadrivalent evidence in adults. Now we're going to look at 9-valent evidence. 9-valent vaccine, the clinical trials are interesting because you already have a licensed approved vaccine on the market that reduced disease. So it's no longer ethical to have a placebo group. So in this clinical trial, we're going to compare 9-valent to quadrivalent. Quadrivalent will be the control group. And we're going to look at how many women with the 9-valent vaccine developed any disease caused by those 5 extra types in 9-valent and compare them to the quadrivalent group. And what we see is almost 100% reduction of disease in the 9-valent group when compared to the quadrivalent types. And again, these women have been followed out to 8 years with no breakthrough cases of disease. When we want to look for 9-valent vaccine, the one I just showed you was up to the age of 26. The older group of women in 9-valent is up to the age of 45. The efficacy was established through immunobridging. So here we look at the antibody levels in women given the 9-valent vaccine in the older group, and these are equivalent or non-inferior to the antibody levels of the women in the quadrivalent group in whom we've already seen efficacy. So now let's look at the males. What is the evidence for vaccinating the males? So here we're going to see the evidence for quadrivalent vaccine in the younger adults up to age 26. Now, we can't look for disease reduction for cervical dysplasia because they don't have a cervix. So here we're looking at reduction of external genital warts and reduction of high-grade anal precancerous cells. And you can see after a very short amount of time, only 2 to 3 years, 90% reduction of external genital warts and 75% reduction of high-grade precancerous anal disease. These men again are followed after the first 2 to 3 years, now out to 10 years, and there are no new cases after that original study period. So we can see excellent long-term potency of these vaccines. For the older group of men up to the age of 45, like the previous one I showed you in women, the efficacy is established through immune bridging, where we look at the antibody levels in males up to the age of 45, and once again, they're equivalent to the antibody levels in the younger men in whom we've already proven efficacy of disease. Now, why do I keep talking about the long-term follow-up of these clinical trials? It's important for us to know that efficacy continues beyond the original 4 years and the antibody responses continue. This shows us that HPV vaccines have long-lasting durability, and to date, there's no need for booster dosing later in our lives. For a lot of us on this call, we're very interested in HPV vaccination in those who already have a history of HPV-related disease in the past or who may currently have disease that we are seeing and treating. because we often might think it's too late to vaccinate those people. Dozens of studies have now shown that if we vaccinate those with disease, we will reduce their subsequent disease. So the first papers that were published looked at cervical disease. So women who were being treated for high-grade cervical dysplasia were vaccinated and compared to those who were not vaccinated. And we see 70-80% reduction in future cervical high-grade disease requiring another treatment. But this finding is not limited just to cervix. We see similar reduction in those who are being treated for external genital warts, with 75% reduction of subsequent recurrences of external genital warts, and similar results are seen for high-grade vulvar disease. So is this finding limited only to women? No, it's not. If we vaccinate men who are being treated for high-grade anal precancerous cells or for external genital warts, we see more than 50% reduction in subsequent disease. So what you're seeing is that we should not discriminate in who we counsel for HPV vaccination based on your age, based on your sex, or based on whether you've previously or currently have an HPV diagnosis or disease. These findings in people with disease have led several jurisdictions around the world to start funding HPV vaccination, especially for women with high-grade cervical disease. So for example, in Austria, in Manitoba in Canada, and in Prince Edward Island, as well as these other regions around the world, we now have funded doses of HPV vaccination for those with disease, which is very important. Now, of course, we do face challenges in HPV vaccine counseling, and I want to spend some time going through some of the challenges that we face. So, what is our rationale? When the patient says, "Why are you talking about this with me?" We know that as adults, we continue to have a risk of new exposure. We know there is efficacy for vaccination at reducing disease, even as we get older. And we've now seen that vaccination can also reduce subsequent disease in people who've previously already been exposed to HPV infections. So, methods for counseling. This is a vaccine to protect you against cancer. These cancers are preventable, and we don't want or need to lose you to this disease. But a couple of things we need to remember. We should not assume that a young adult, whether male or female, was already vaccinated in our school-based program. Because, for example, here in Ontario, we know that last year less than 50% of kids were vaccinated in our grade 7 program. And also, as we talk about the value of HPV vaccination to our adult patients, remember that those adults are now or will become parents of children in the future. And if that adult understands the value of vaccination, they're going to be more likely to consent their child in the school-based program. So we really see a dual benefit when we counsel adults. What about the problems, issues related to cost? Well, we often think that this is a large barrier. And we did a survey through the Society of OBGYN of Canada about 5 years ago. And we asked providers, both family doctors and specialists, and patients a number of questions about their level of knowledge of HPV and HPV vaccination. And for me, one of the most interesting questions we asked was, what is the number one barrier to your patients getting vaccinated? This was asked of the providers. And regardless of whether you were a specialist or a family physician, more than 90% of them said definitely cost is the number one barrier to my patients getting vaccinated. But if you ask the patient the exact same question, only 18 to 20% of patients said cost was the number one barrier. In fact, what they said was my provider didn't talk about it. So the lack of recommendation was identified as the number one barrier to them getting vaccinated. It doesn't mean you didn't talk about it. It means the patient didn't hear or remembering you talk about it. What about upper age limit? Because we get that question a lot. Well, first we look at Health Canada, and that's who approves vaccines in Canada. And you can see that the quadrivalent and now 9-valent is approved in Canada for males and females to the age of 45, and the bivalent is approved in females to the age of 45. Bivalent wasn't studied in males. That's the reason it's only approved in Canada for females. But when we look at the number of indications, that also differs. So for cervical disease, but also for prevention of vulvar and vaginal cancers, anal cancers, and precancers, external genital warts, as well as prevention of oropharyngeal cancer. We go, though, beyond Health Canada's approval, and we look at the NACI recommendations on who can be vaccinated in Canada. Of course, they approve and recommend vaccination in those individuals to the age of 26, but NACI supports vaccination over the age of 26. And you'll notice that they've chosen to put no upper age limit. NACI has always recommended vaccination of those with a current or past history of disease. Our Society of GYN Oncologists of Canada has gone one step further and not just support vaccination of those over age of 26, but actively recommending universal HPV vaccination, so stronger language. What if a person has had a previous quadrivalent or bivalent vaccine? We often have that question, should I be vaccinated with the 9-valent vaccine? The 9-valent vaccine, the benefit that it offers over the original quadrivalent and bivalent vaccines is that it now protects us against 90% of strains that can cause cancers, where the previous protected us against 70% of strains. So we have 20% additional coverage with strains that can cause cancers in the 9-valent vaccine over the quadrivalent vaccine or bivalent. Now, this is always a tricky one, isn't it? Well, I'm in a stable relationship. I'm married with 2 kids. Why are you talking about this with me? Well, there's a few different reasons. Number one, our stable relationship may break down in the future. New partners may enter our existing relationship with or without our knowledge. And we know that vaccine may help suppress reactivation of previous HPV infection that we had in the past. And we know for sure that eventually one of the 2 of us in our partnership will pass away. The chance that we are going to have a new lifetime partner in the future is very high. How about some of the logistics and the implementation? Well, we as providers need to strive for consistent messaging within our team. And that includes our front office staff, our nursing staff, our physician staff, and our trainee staff if we're in a teaching setting. We also should consider the extended team, the pharmacist who may be involved with our patients, and the other healthcare providers that may be involved with our patients, naturopaths, homeopaths. All of us need to be on the same team with the same messaging, because it doesn't really matter if I recommend to you that you be vaccinated and I give you a prescription to be vaccinated. If you call back and my receptionist, because you're just not sure of what to do, and you say to the receptionist, gee, I don't know, should I really do this? And if the receptionist says, oh, honey, you're old, you don't need to do this. Honey, you have, one partner, you don't need that. Then it can undo all of the good in the recommendation that the nursing staff and the medical staff may have given to that patient. So we all have different types of practices, and we need to look for the opportunities in our specific practices when we could bring up this type of discussion. So for me, that's easy at a cervical screening visit, but also we can think of it in contraception discussions anytime we're testing or treating for a sexually transmitted infection, of course. Why would I say travel vaccination? Well, any visit for a travel vaccine, we know the chance, especially with young people, that they will have a new sexual partner during their travels is very high. So it actually should be included in our discussions about travel vaccines. Annual flu shots have now become really an annual vaccination visit, because flu shots are now linked with COVID vaccination discussions, and they are also an opportunity for us to discuss HPV vaccine. Mental health visits, the patient often is coming and may be linked to a change in their relationship status. So this again is an excellent opportunity to discuss HPV vaccination. Remember now, as we head next year into primary HPV testing, this will become an excellent time for us to discuss HPV vaccination at the cervical screening visit. We can discuss the importance of HPV vaccination at the time that we're doing the test and also when the test results return. And this is true, and the discussion can happen regardless of the results. So I could say to you, Mary, your HPV test has come back positive. We know that when we vaccinate those individuals who are HPV positive, we can reduce the chance that they will have a subsequent recurrence of disease going forward. Mary, your HPV test is negative. This is great news. You don't have any HPV on the test results. This is an excellent time for us to vaccinate you to prevent an HPV infection in the future. So I can spin the discussion regardless of the results. It's an opportunity to talk about it. We need to be proactive and not wait for patients to ask us about this vaccine. We have to deliver the information, and it's helpful if we can know ahead of time who is and isn't vaccinated for HPV, and we can often do that through our intake questionnaires. We talk about it verbally, but we know that patients don't remember probably 80 to 90% of what I've just told you today. So giving printed information is very helpful. We can give it to the patient, but I've learned it's also a good idea to have that information in the waiting room and also in the exam room because patients wait a long time to see us. Especially for younger individuals, they may prefer web-based information. The most effective way for us to vaccinate is to directly stock vaccine in our clinics, or we can talk about it and give the prescription to the patient. Now, in the era of electronic charting, we can develop our own electronic chart reminders, pop-ups that remind us to discuss it with the patient. And we can even go beyond that and be proactive and push out e-blasts to patients even before they come for visits. So I think this is really important that we have the proactive approach both to patients, but we can also push it out to providers. Awareness initiatives can be very helpful. So awareness campaigns like Movember can be very effective as well for HPV. Those who practice, for example, in the university setting can have mobile vaccine days or weeks in the university where we go out into the student hubs or where we have walk-in vaccine days in our clinic. And the purpose of these awareness initiatives to provide information, to answer questions and can address concerns, and to provide easy delivery of vaccines, so the opportunity to vaccinate. And I want to point out when we have more than one dose, we can give a dose today at the clinic. You could return to clinic for remaining doses, or I could fax a prescription to your pharmacy with a note to the pharmacist to remind the patients, and they're very good at that. And the pharmacist could administer the remaining doses. I want to spend a few moments talking about the NACI update that was just 2 months ago now at the end of July. So NACI came out with an update July the 24th, changing their recommendations for dosing intervals. So for ages 9 to 20, NACI now recommends 1 dose of HPV vaccine instead of 2, used to be 2 from the ages of 9 to 14. They recommend 2 doses of HPV vaccine at 0 and at least 6-month interval for ages 21 to 26. And over the age of 26, they say 2 doses, again at time 0 and at least 6 months later. Remember, these NACI recommendations currently are off-label in Canada, so this is not what the manufacturer recommends. Provincial public programs have still stayed with 2 doses, except for Quebec, which has announced 1 dose. Now, that may change in the future, but at the current time in Ontario, 2 doses is still recommended in our school-based program in Ontario. One exception is immunocompromised individuals, and those living with HIV should still continue to receive 3 doses over 6 months, 0, 2, and 6 months. Now, some cautions, and these are my own opinions. Remember that provincial vaccine coverage rates are still low across the country, and Ontario is particularly low, less than 50%. Countries that have adopted a one-dose vaccination program in their adolescent programs, like Australia, like the United Kingdom, have very high vaccine uptake rates, more than 90%. That is not true in Canada. Because we don't have high vaccination rates, we do not have herd protection of the unvaccinated individuals. The one-dose regimen is also recommended in countries that have decreasing disease rates caused by HPV, and that is not true in Canada. Cervical cancer, in fact, is not even stable. It's increasing between 2015 and 2019. We have no national registries for surveillance, as many other countries, like the Nordic countries, do. So we don't always know who is vaccinated. We don't have good screening national registries, and we don't have good disease registries nationally for precancers and cancer cases. And this means that if alternative dosing increases disease, it will be very challenging for us to recall for booster dosing if it was required to get a second dose because we don't have a coordinated national registry. What was the NACI statement and update based on? It was based on 3 clinical studies. There was only one randomized controlled trial that was considered, and this is called the Kenshi trial, which was done in Kenya, which only took place over 3 years, 36 months, 2,200 female-only individuals, and 2 other observational studies which were not randomized to one dose. No male studies have been done looking at alternate dosing, and this is really important when we consider protection for oral HPV infection and oropharyngeal cancer in males. And this is true that the long-term duration of one-dose protection is unknown. There is a very large one-dose randomized controlled trial called Escudo, which will be reported in the next 12 months. And this involves more than 20,000 individuals. And this is the study that most of us are awaiting with great anticipation to see if this study will compare one dose to 2 doses, where the previous studies only compared no doses to 1 dose. As I mentioned, all alternative dosing is off-label in Canada. Does this mean that we should be disclosing this to parents and adult patients? Ethically, it does. As the provinces and territories may move to 1 dose in our school-based vaccination program, remember that the reported vaccine coverage rate will automatically increase since 1 dose is now considered completed. And that means that even if no additional children are vaccinated, that we will artificially see an increase in our vaccine coverage rates. And people will say, see, going to 1 dose was a big success, but no additional children were vaccinated. We need to really develop comfort and confidence with the subject of HPV vaccination. Patients definitely sense when we are uneasy with a topic. So we must develop confidence with our subject matter. If you don't have confidence or if you have questions, feel free to ask us for advice. We're always available. Try to anticipate the questions. Think about the answers in advance to those questions that patients will ask you. Because I can tell you there actually aren't that many questions. I've pretty much heard them all before, and I know what I'm going to say before you ask me the question. We need to set an example. We need to educate ourselves, and we need to be vaccinated. We need to believe in the difference that vaccination can make for HPV. So be an advocate, educate yourself, speak to not just your patients, but to your friends and your family about the importance of prevention. Get vaccinated yourself. Be a leader in preventative health care. And most importantly, remember our messaging must be simple. It's most effective when it's simple. They want to know 3 things. Does this vaccine work? Yes, it does. Is this vaccine safe? Yes, it is. Most importantly, do you recommend it? Yes, I do. Let's vaccinate you today. And we forget the strength of that vaccination recommendation is the most important factor in success in getting patients vaccinated. So I am going to stop there and I'm going to stop sharing. so that we can then head into any questions, comments, or challenges that you may have. Okay, I'm going to see there's both in chat and in Q&A, right? So how about we start with the Q&A and then I'll go back to chat and then you guys can keep helping me. Would it be recommended that individuals who received quadrivalent vaccine in school should now receive 9-valent in adulthood, even if not covered by OHIP or insurance? So that's an important question. Number one, the government is never going to pay for all of the kids who originally got quadrivalent vaccine and now 9-valent is available. So yes, this would definitely be in the private space. So it would not be covered by OHIP. It might be covered by your employer health insurance. So about 40 to 50% of health insurance plans through employers do cover vaccination, and it would be covered even if you already had a quadrivalent vaccine. It's more the question of value. Is it recommended? So do I talk about that with patients who had a previous first generation vaccine? And I would talk about it with you because I think I need to give you the information so that you can make the best informed decision for yourself. And that would be that we are going to have 20% more strains that can cause disease and cancer in the 9-valent vaccine coverage than we do in the quadrivalent vaccine. So that is what, in fact, I do with patients. I do talk about it. Okay, let's go back to chat. So a 50-year-old male with genital warts, do we give him HPV vaccine? And what about vaccination for his wife? That's a great question. Number one, for the patient in front of us, the male with external genital warts, definitely yes. I'm going to talk about vaccination of the person in front of me because I know that I can reduce the subsequent recurrence of external genital warts by 50% in that patient. And I think you bring up an excellent point about we must continue to talk about vaccination of you, the patient in front of me, but also your partner or partners. And that is actually how I say it, because we should not assume that the person has only one partner. We should always be inclusive and say your partner or partners and your future partners. So yes, I would recommend it and try to get them vaccinated. So that was also the question here. Is there a need to vaccinate the partners of patients with low-grade or high-grade disease? Yeah, we know that exposure has happened, right? And so we don't think of it ever being too late to vaccinate you, no matter how old you are, or no matter if exposure's already occurred. Third question there, why do we give 2 doses in school and 3 doses in clinic? That has to do with age. So the kids being vaccinated in school across the board are going to be age 14 or younger because it's grade 7 and under. And it's been shown that 2 doses of HPV vaccine in that younger group was equivalent in the antibody levels as for 3 doses in the older age 16 to 26 in whom efficacy had already been proven. So that's why you see around the world 2 doses is given 14 and under, and that is on label with the company because there is evidence to support that. So Ricardo asked, do you recommend following NACI recommendations, meaning 2 doses or 3 doses recommended by the manufacturer? And that is a very tricky question for all of us to try to struggle with right now. So I can tell you for myself, I'm not yet convinced that the 1-dose evidence is strong enough because of the quality of the evidence. And that's why I mentioned the Escudo trial that is going to be coming out. It may be preliminary announcement this November at a national or international meeting, or it may be next March, the first readout of that large 20,000 clinical trial. And all of us are really, really interested, and it may indeed support that 1 dose is equivalent to 2 doses in that younger age group, but we don't yet know that evidence, in my opinion. So I will continue to follow 2 doses for kids 14 and under and 3 doses for those 15 and older at this time. My patient has tonsillar cancer positive for HPV 16. She's 45 years old. Do I vaccinate her and her partner? So you're seeing a theme here, right? And you probably know what I'm going to say. So definitely, I would vaccinate the patient with tonsillar cancer, and I would definitely vaccinate the partner. But I would also vaccinate the 45-year-old woman who doesn't have tonsillar cancer, and I would also vaccinate the partner who doesn't have tonsillar cancer as well. But that person is especially at risk. So I think at-risk groups are an interesting topic of discussion. People who are at higher risk. So those who are immunocompromised, those people living with HIV, even if they're suppressed. There's some groups that are at higher risk that we don't remember about. So sex trade workers, transgender individuals, very high risk, and victims of sexual abuse. And we must remember to continue to counsel all of these groups and provide opportunity for them to be vaccinated, however that may be. So often I find in these high-risk groups, they may be more comfortable that I do the vaccination myself, but we're so lucky in Ontario that our pharmacists can vaccinate as well. And I've found the pharmacists to be really a partner in HPV vaccination in practice. Okay, anybody else with questions? Caitlin, you just jump in and tell me if I've missed any. Oops, I think there's one more. No?
And I'll just note, I did activate your mics and cameras, so if you prefer to come off mute and ask the question directly, that's more than welcome.
Yeah. Yeah, I'm just looking there. There was a really interesting last week when I mentioned I was in South Africa at the International Congress of Pharmacists, and one of the speakers that I was on the panel with spoke to us about a study they had done of parents in their school-based program asking, who do you feel is the most trusted source of information about HPV vaccination for our school-based program? And what was really interesting is it's not what you would expect. It's not healthcare providers in their setting in the school-based program. The parents identified the teacher as the most trusted source of information. Now, I think for us in Ontario, this may be very illuminating that we need to involve teachers more than we have at informing the parents that this program will be coming in the fall. So I would say in the springtime is the time for the teacher to start talking about it with the parents and for us to get teachers on board. And I have a colleague in British Columbia who's a pharmacist, Ajit Johal, and he started a very interesting program after COVID when HPV vaccination, rates fell. He started an HPV vaccination after school program. And he, as a pharmacist, goes into schools not to vaccinate students, to vaccinate teachers. And the more he vaccinates teachers, they found a direct correlation with increasing uptake in that school in their school-based program. And I think we need to think about these creative solutions to improving our vaccination rates, both in adolescents and in adults. Patient with ascus said she is not sexually active. Is this from HPV? Well, you're going to know that answer soon next year as we move to primary HPV testing and away from cytology as the first test. So HPV testing is tricky for when it's your first time counseling about that. So HPV testing that we have and that we will have in primary screening, remember, is not for all HPV types. So if I had a low risk type, let's say a type 6 or 11, low risk types are not looked for in our standard HPV testing. So it would be reported as HPV negative if I had a type 6 or an 11, meaning if I went on to get external genital warts, etc. So that's a little tricky. Don't be fooled into thinking something is not caused by HPV just because the test for high risk type says that it's negative. But the patient that you have who says that she is not sexually active, that brings up another good point, is how do we define sexual activity? And we need to really destigmatize that it means penetrative vaginal intercourse, because it doesn't. We can have HPV transmission from intimate contact. And that's the word I like to use. I don't always use sexual contact, I use intimate. So any type of intimate touching, so oral, genital, oral, etc., doesn't require vaginal or anal penetration for transmission. So we know that people carry HPV on their genital mucosa, and this is how transmission can occur in individuals who may not have had penetrative intercourse anally or vaginally. Any other questions?
I have a question, and I apologize if you did answer this. With the transition to HPV testing, do you foresee that we will be able to test for anal cancers at that point?
Short answer, no. Long answer, can we? Yes, it can be done. It's not done the same way. It's the same test. So HPV anal testing is done in high-risk clinics. So it's done in our MSM clinics and our HIV clinics. The people that will do this will typically be those in infectious diseases, sometimes gastroenterologists who staff these clinics. And the problem in Ontario is that we just don't have that many of these clinics available to us. So number one, availability. And number two, reading the test is a challenge for the cytopathologist. It's not the same as reading traditional cervical cytology. So you might know with an HPV test if they're positive or negative, but what do you do then? Who do you send them to? And we really don't yet have capacity for testing, anal testing, as well as cervical or vaginal testing, unfortunately. How you do that? It's actually like a cyto brush. Remember the old-fashioned cyto brush we used to use for cervical screening? We had the spatula and then we had the little pipe cleaner thing. It can be done with a cyto brush, or it can be also done with a Dacron swab, and then it's sent in the transport medium, which is the same HPV. So it's not recommended at this point in time. Probably won't be. And there's nowhere in the world that it's recommended except in the high-risk groups. And that leads to the question there, does Ontario offer HPV testing for men? No, unfortunately, it doesn't. And that's true, except in clinical trials, that's true around the world, that we don't do HPV testing in men except in those high-risk groups of men having sex with men and men living with HIV. Just going to go back to Q&A. No. And I think that, as I mentioned earlier, that the move to primary HPV testing, I think for all of us here on this call is going to be really the opportunity to raise awareness, because suddenly we will all be talking about not just screening you for cervical cancer, we will be talking about HPV testing. And I have to tell you the answer to your test result. I can't just ignore it. I have to tell you your result came back and you're HPV negative, or your result came back and you're HPV positive. And as I said, regardless of your result, it's an opportunity both at the time of the test and at the time of giving the results for us to again say, you're eligible for HPV vaccination. This is something that we recommend, etc.
I just want to add that I think one of the barriers, at least in my own personal experience, is that when you're school-based age, you don't recall what vaccinations you've received. That was up to your parents. So I think that many adults that didn't receive it, they assume that they got a vaccination in grade 7. They're like, yeah, I'm okay. But they actually never received that specific vaccination until they look at their yellow card and realize that they never received it. So I think that's why it's so important to have that conversation as well, and remind an individual to go look at that yellow card or another record of some sort. But
yeah, so I think record keeping in Ontario is problematic. And yeah, if you're lucky enough to be able to find your yellow card, that's one thing I know. It's funny because every time we move houses, I find that yellow card for ourselves and our kids in the kitchen drawer. And I move that yellow card, thank goodness. But a coordinated national registry would be really, really helpful because also people move from province to province. And so we just honestly often don't know. There would actually not be harm in revaccinating somebody if you had an unknown vaccine status. So there's no harm been seen. To be honest, with extra dosing. It's just, we try where possible. Public health doesn't really have great record keeping from, especially the early days of school vaccination. And so that I've found patients find is a huge challenge. And a lot of parents and even kids who've now grown up assumed it was mandatory. And as you know, of course, it's not mandatory. So I think that's a challenge. Truly in Ontario. We have a really specific problem of uptake in Ontario. You might think that often urban settings have higher vaccine coverage rates than rural settings. In fact, for HPV, it's the opposite. So our provinces like Newfoundland, which are much more rural based, have excellent HPV vaccine coverage rates. And we think that's for two reasons. First of all, they bring their vaccine age down. So to grade 4, when you are recommending and vaccinating kids age 9 to 10, the parent assumes this is a vaccine for health, nothing to do with sexual activity. That's one reason. Also, in smaller rural settings, there's much more trust in the public health unit. And so if the public health nurse says, this is important for you to be vaccinated, they do it. And in our urban settings, this is much more of a challenge for us. We are more skeptical. We may not have contact with them. And so I think, especially in our urban settings in Ontario, this has really been a challenge.
I think you made an excellent point that there's often that tie together between the HPV vaccination and sexual activity. So I think a lot of parents are hesitant when they're thinking about their very young child and later in life and whatnot. But there's so many other great benefits, and you've outlined all of them essentially during your presentation, and that was fantastic. I know I learned quite a lot from your presentation, so thank you.
Yeah, I think it's funny because I gave another talk earlier this afternoon to a task force here in Ontario, and this was more based on the school-based thing and messaging, and having an announcement message instead of permissive. Permissive statement is like, do you want to participate? Yes or no. Whereas a presumptive announcement is, Taylor is going into grade 7. We vaccinate all our children against hepatitis, meningitis, and HPV in grade 7. HPV vaccine is a vaccine that prevents 6 types of cancer. So what you hear is, this is an expression of love. We do this because we care about our children. And this is a cancer prevention vaccine. And this is normal. We do this in grade 7. And what you didn't hear me say is, this is a vaccine against sexually transmitted infections. And you don't hear any of the negative of, this is a vaccine that we want to give before the onset of sexual activity. Because in fact, it's beneficial both before, that's the best time, but also after the onset of sexual activity. And we could learn that in adult medicine, I think, too.
Amazing. Dr. Durant, thank you so much. We sincerely appreciate your time and coming out to speak with us this evening. Oh, sorry, I'm seeing a few more questions come frantically into the chat, so we don't need to close out now. I'll let you read out those.
Yeah, so the one was the challenge in Ontario with foreign immunization records that need translation. Yeah, that's very true.
I have heard that public health will do that translation. I don't know if others have experienced that, but that was something a colleague had shared with me recently.
I usually get the patient to translate it for me, right? Because I have that all the time with their cervical screening results from other countries. So, and also Google Translate can be helpful too.
Sure. And looks like people are interested in your slides. I'll let you comment to that, Dr. Durant.
That's something that I don't do. These take me not just days, but weeks to develop. And I've often had times where my slides have appeared in other people's talks without credit, so I prefer not to. Thank you.
Absolutely fair. Yeah. Great. Okay. Well, we're so glad that everyone was able to join today, and we're so thankful for your time. This was really, really great information. I definitely learned a few things myself, and need to go find my yellow card. And yeah, we really, really appreciate everyone coming and asking their questions. And I see a lot of thank yous and amazing chats and amazing talk in the chat. So I think everyone appreciated all the information shared today. So thanks again.
Thank you.
Thanks so much.
Take care.